There's always a need to do research and not just like, oh, my prior experience tells me this is going to be a problem. Like, it doesn't mean your instincts aren't useful, but you can never stop doing research.
Welcome to UXR Geeks, where we geek out with researchers from all around the world on topics they're passionate about. I'm your host, clinicial, a researcher and a product manager, and this podcast is brought to you by UX Week, the UX research platform for recruiting, contacting, analyzing, and sharing insights all in one place. This is UXR Geeks, and you are listening to an episode with Gyles, who is appearing on the podcast the second time. And it was my wish to meet him, amongst others, in my last recordings. I'm happy he came and he spoke about a very important topic, which is the bias and the stereotyping in healthcare, and how we actually help as researchers to solve it. Tune in. Gyles, welcome back.
Hello, thank you for having me.
How are you? How have you been?
I've been good. It's been a while since we last had a conversation. A lot has happened. Busy with parenthood, busy with various projects and clients around the world. But yeah, I'm in a good place.
Nice. So we teamed up again to talk about healthcare, UX in healthcare, the research in healthcare. And you are bringing up again a very interesting topic. So I'll leave it up to you to explicate on it, and then I will maybe interrupt you with some small questions.
Sure. Yeah, I think what would be great to cover this time, just building on our wonderful previous conversation, is really more about a lot of the challenges that I've observed and personally faced when working as a clinical UX professional and specifically doing user research in healthcare. I think there is a common sense aspect to it from the general public, and further a common sense aspect from other UX researchers on why is healthcare going to be more difficult. But it's when you actually do the work, you work on these projects, you realize it's even more complicated than you could probably imagine. So that common sense aspect is, well, obviously we're dealing with busy clinicians, we're dealing with people who are stressed, people who are sick, people who might even be unconscious, so you can't even communicate with them. And obviously healthcare is a global issue. Everybody deserves to be healthy. So there's complexity that people can just appreciate off the top of your head. And then as a UX researcher, you know that actually it's useful to not just speak to one or two people. You might want to speak to dozens of people, even hundreds of people sometimes, depending on the context. So access is going to be a problem. But it gets even more complicated than that. I think what non-clinicians who get into digital health fail to fully appreciate until they start working on the projects is how much knowledge they need to know about healthcare to really understand everything. So again, there's a common sense aspect. If you've not been to medical school, then you've not been a nurse, you've not been a pharmacist, there's loads of stuff they talk about that you don't know about. But even when you have trained as a clinician, your first day at work, everything is confusing. Everything is new. Because there isn't really, apart from a few rare exceptions, there isn't really one way of doing things in healthcare. You're going to see variations within different hospitals, within a hospital, even within a department and within a speciality. You could get two heart surgeons working in the same hospital who might still do the same heart surgery ever so slightly differently. It's this sort of variation and almost randomness which is part of the reason why things are quite complicated. There's always a need to do research and not just like, oh, my prior experience tells me this is going to be a problem. Like, it doesn't mean your instincts aren't useful, but you can never stop doing research. There's always something new to come, some new way of working, just something random that just happens that catches you off guard. It's extremely, extremely common in healthcare. The other thing that is particularly challenging is the regulatory side of things. So again, we all know that privacy, security of data, patient data, clinical data, we want to keep it safe. But what does that mean as a researcher, how you can access the data, actually do your analysis with it, to share that data with others and bring changes? And what that looks like in Europe is a little bit different to what it looks like in America. And it's a bit different to what it looks like in different other countries around the world. There's always something new to learn. And so I think it's what makes it fun, but it can also make it very daunting and overwhelming when you get into digital health as a UX researcher, for sure.
Do you maybe have an example? Because I can imagine, the complexity of healthcare. What is maybe an example of you not understanding before the research the system well enough that it even surprises you?
So I'll use a really great example from some years back. I was working for a big pharmaceutical company and they worked on a project called MediCoach. This is a telehealth coaching, so remote health coaching service for patients living with type 2 diabetes living in Mexico. Now, the service is free and it's clearly of benefit to people. It's going to help them understand more about their type 2 diabetes, what they can do about their diet and nutrition and exercise and keep them healthier. Now, despite it being free and there being unanimous praise for the service from patients, it was only about 20% of patients who registered for their first health coaching session actually completed all 5 sessions about 5 to 8 months later. Just about 20%.
Okay.
They even got a glucose meter and some other little bits and pieces to incentivize them to use this free service. And there was so much talk from colleagues, whether it's in the main office in the pharmaceutical company or some of the health coaches about, what we could be doing to make the service better. And there wasn't that step backwards to look at everything holistically and be like, well, isn't it a bit of a red flag that everyone says that this service is perfect? Nothing in this world is perfect. Nothing. You can't assume that 100% of patients had nothing bad to say. And partly that was a cultural consequence or initial sort of findings that was done internally, is that culturally, the people in Mexico, they don't want to offend the clinicians, especially when someone's gone out of their way to give them something for free. So back to your question, though, is like an example of why would it be so complicated is where was the true understanding of the lived experience of these patients? Now, researchers would appreciate that such research needs to be done. I can understand that other researchers would know that. Because when I worked on that project, I had a friend of mine who is based in Chile help to do that research in Mexico. Instantly, we knew we had to do a lot of research with patients. But I think what wasn't also appreciated is even if you do research with the patients, you might still confine yourself to what I like to call participant dependent research. So you're interviewing people, you might even be observing them, and you get a lot of insights from that. But there is a huge wealth of data that you can learn about population health as well. And I think that was not being considered from the get-go. And I pushed to do that. And it was quite worrying, the data. It was highlighting that on average, particularly amongst the patients that we were dealing with who were using a free service, it's normal for them to have very low numeracy literacy skills. It's quite normal for them to not be able to afford a contract that allows them to make many calls out. They can receive calls and they can even use Facebook and WhatsApp for free because of the data plan that they have, but they wouldn't have like a gigabyte of data. Like I take for granted in Europe, I think my contract is about 25 gigabytes or 40 gigabytes. In some parts of the world, they're lucky to have 1 gigabyte a month to use. To put into perspective, one Uber journey can use about 30 megabytes of data. So you can see how the data can go really, really quickly. I highlight this to say that you have to really try and understand every aspect of the average patient's life, but also, and it's the case also for clinicians, the average clinician's life, but also those who are going to be the most trusting, the most willing, the most engaged, the most switched on, because they're like the super users, so to speak, or early adopters. But then the other extreme, those who are the most hesitant, the most afraid, the most anxious, the most resistant to this new way of working, this behavior that you're trying to understand or change. And when you start thinking from that perspective, like people who are filled with doubt or dread, or those who are just so excited and so keen, guide your research towards those sort of extremes. It's much more useful to do that in healthcare. It's useful probably in every industry, but particularly in healthcare, you get those extreme type of personalities that you've got to try and do research with. And that's what we did with that project. And that
Mhm.
allowed us to understand that actually make this solution much simpler. Still do your telehealth coaching service, but send information between the coaching sessions via WhatsApp, which is free, and use infographics because images communicate information much quicker than words do. And that then scaled from anywhere from about 400-500 patients per year to now that about 3-4 years has passed. And just in Mexico, it's spread across all the other countries in Latin America. And there's probably about 20 or 1,000 patients that have now gone through the service. So we simplified it. Simplifying was important.
You simplified it based on pretty complex research because if I try to summarize, it's the qualitative research speaking to the users, it's the macroeconomical,
Yeah.
in cultural insight. So the secondary research come very handy.
Mhm.
But I have to admit, what I most love about it is the critical starting point. Like nothing is perfect. I just
Yes.
not believing, oh, this is a great product because everybody's saying so, and being suspicious to that,
Yeah.
which is also a very important thing. We'll be right back after a short break with a commercial message from our sponsors. Hey UXR geeks, you know this podcast is brought to you by UX Tweak. I've tried several UX research tools before, and most either make recruitment a nightmare or overcomplicate the analysis. UX Tweak is the first one that actually does both well. I can recruit participants from over 130 countries with solid quality checks and detailed profiling, and it supports both moderated and unmoderated studies, and analyzing results doesn't feel overwhelming. It just makes my research smoother. So if you're curious, go to uxtweak.com website and start for free. No credit card and no strings attached. From what I know with discussions with you, you are strongly motivated by your own life. So what is the case on your side and why do you make sure that you do great work in healthcare?
Yeah, it's a good question. So there's a few motivations. The first one is tied to my identity as a doctor, I suppose, and I suppose also as a Christian. Like, how am I able to help other people have better lives? When you train as a doctor, as cliche as it sounds, really you're doing it because you want to make other people happier and healthier. That is the general motivation. Some people also talk about fame and fortune and things, but really it's about how you're going to help someone else. But I think what is particularly important is the fact that my wife also lives with sickle cell anemia. I'll explain that a bit more. But with her living with sickle cell anemia, she's my life partner. Of course, I'm going to see how I can put my skills and training to good use to improve her health. So, sickle cell anemia is a variant of sickle cell disease, which is a hereditary disease of red blood cells. It means that when the red blood cells give off oxygen, if you remember from school days, the blood goes away from the heart and goes to your cells, gives off oxygen, comes away, takes the toxins in the blood away, and then goes back to the lungs to pick up the oxygen. So when red blood cells, for someone who's got sickle cell, gives off the oxygen, they go into what's known as a sickle shape. Sickle looks like a crescent moon sort of shape. And with a crescent moon, it's got like pointy ends to it. Now, if you have loads of the red cells that become sickled, they can bunch up a bit like having a clot, but they bunch up and get stuck in very, very tiny blood vessels, the smallest blood vessels that would serve like your joints and your muscles. And the trigger for that, other than giving off oxygen, would be stress, maybe infection, and particularly for my wife, is cold weather or extreme temperature changes. So if she's somewhere very, very hot and that goes to like a average room temperature, that can also be a trigger for a pain crisis.
Oh, okay.
Yeah, and it's quite serious having a sickle pain crisis. So this is an episode when you have a lot of those sickle cells getting stuck in joints, in muscles, in the blood vessels, tiny blood vessels. And it's considered a medical emergency because if that continues without getting any better, it can lead to end organ damage because you're stopping the blood flowing properly. And it's really excruciating pain when it happens as well, because you've got part of the body slowly dying. So it's very simple treatment actually when someone has a pain crisis. You give them intravenous fluids, you give them very strong pain relief, morphine, not just paracetamol or ibuprofen. It won't do anything. And
Mhm.
in bed rest. And if you do that very, very quickly, say like within an hour or so of the symptoms starting, that person will probably have a full recovery within a day, even can be really, really rapid. So when my wife has
You,
a pain crisis at home, we don't have, all the equipment to do intravenous fluids, but she'll drink a lot of water. She will take some strong paracetamol and ibuprofen at home, do deep tissue massage to try and move the blood around the body a bit better, and she can recover later that day. A few episodes she's had to be hospitalized with it over the years, and that's where you see suffering big time. And what's quite sad about that suffering is that it's very, very avoidable and extremely prevalent, though, amongst patients living with sickle cell.
It's hard to even process this, not to even go through it. And I'm wondering, we all have experiences from the health system, either from our life or from lives of our loved ones, as you have. Where do you see the biggest problems happening?
I think the common denominator for problems in the world, let alone in here, is communication or the lack thereof. So, with the case of someone with sickle cell, it will be that the patient almost always knows exactly what they need. They know they need IV fluids, they know they need morphine, they're asking for it. But it's not normal to go to the emergency department and ask for morphine, especially if you don't look like you've had a gunshot wound, you don't have a knife in your back, you haven't just come from a massive road traffic accident and your legs are broken or something. Why are you asking
Mhm.
for morphine? When you see the patient, you feel like they're not that unwell. There's a bias that a lot of clinicians can have to even assume that Black people and most people with sickle cell are of African Caribbean descent. And there's a perception that we have a higher threshold for pain. We don't. We absolutely do not. It's a total myth. But because of that perception that, okay, we'll start you on paracetamol, ibuprofen, or if they are going to give morphine, they'll give a very small dose, which doesn't do anything. And it's these sorts of things that is part of the problem, is that the patient knows what they need. It's not the first time they've had this issue. They actually see specialist hematologists about their disease, and they should have a care plan that stipulates exactly what needs to be done when they have one of these sickle pain crises and go to the hospital. And so when they're not being listened to, it's extremely offensive on a few grounds. One is just the simple aspect of, well, the patient is making a respectable request, which is tied to best practice in treating the patient. Why are you ignoring them? The next part is that you're assuming that they're lying to you, or you're assuming that they are being overzealous with their request. So therefore, you're going to ignore the request and do what you think is best. Again, is insulting because you're dismissing what they are actually saying. But it's also the fact that the nature of working in a busy hospital, when a doctor or whoever else has rights to prescribe the morphine, writes the prescription, it doesn't mean the patient gets the morphine straight away. It doesn't even mean that they may even get it in the next half an hour, because 9 times out of 10, depending on where you are in the world, when morphine is prescribed, it's classed as a controlled drug, which means you have to have another clinician check everything that's being done and even physically be there when the medication is given to the patient. So they both look at the prescription independently. They both look at what has been drawn up as liquid morphine to give to the patient. They both have to confirm with the patient their name and date of birth and look at a wristband to confirm the name and date of birth matches that on the wristband and on the prescription, just to make sure that it's safe for this patient. And sometimes the ward doesn't even have morphine. So the prescription is given at 10, right? The patient needs it at 8 a.m., but the patient still might not get that medication until 11 a.m., midday. And then when they are given it, they're given a small dose, 5 milligrams at 12, and they're told, okay, you have to wait 2 hours for another dose. So the patient's been in excruciating pain from 8 a.m. It's now 12, and they still haven't been given enough pain relief. So at 2 o'clock, they're then given 10 milligrams, which still is not enough. They need 20. So it's then another 2 hours. It's now 4 o'clock in the afternoon. Now you see why people are not getting any better, because of the delay in treatment for an emergency like a heart attack, stroke. It's still taking them 2 hours to get a prescription, but then many, many hours to actually get the dose that they deserve. It's not always the case, but the vast majority of the time, that's what happens.
One thing that I see there is the bias, because
Mm.
you see patients are mistreated or even not diagnosed, sent home, because you are hysterical, whatever. The other side is when it comes to my mom, like, why the patient doesn't have a badge or something
Yeah.
in a digital system where it's like, okay, this is where we deliver the morphine as fast as possible because we have proof. We don't have to debate about it.
Two main things to explain. One is what's going on in the mind of the clinician. I'm going to come back to that. But the second part of, why isn't there care plans being used? So very often a patient actually will have a care plan if they're seen by a specialist doctor. If there's a specialist that's involved, very often there will be a set of instructions on what to do when this patient has a serious issue. This is their care plan. And it's a personalized care plan if it's written specifically for that patient, or there is going to be generic care plans, which are otherwise going to be considered guidelines on what to do for that patient. So generally speaking, we know what we should do for a patient if they have a stroke. So same thing that would be done for sickle cell. So there are care plans that are generic for anybody that's got general presentation, or is something that's been personalized to that patient. But until someone sees the care plan is useless. And that's a big part of research I did when I did my master's in human computer interaction. I was looking at, so surely the hematologists are trying to get information, but what they'll do is they'll create a care plan, particularly in the UK. I can't speak for many other countries, but in the UK, in the NHS, the hematologist will write this care plan. It goes into the patient's digital record as a letter. Now, depending on the electronic health record system that's being used, the letters, from like an information architecture perspective, is far removed from where the first doctor or first clinician ever seen that patient is going to check out on the digital system. In fact, if that patient has gone to the emergency department, they may never look at the patient's digital record. They may only just see what is the information they gave at reception and the triage nurse to say why they came to the emergency department today. So that care plan never gets seen. The other option is the patient does go to the emergency department very often. So even though the emergency staff there have a high turnover and there's different rotas and shifts going on, they will put that care plan on a wall in the doctor's office. And everybody just says, when this patient comes in, there's their care plan on the wall. But sometimes it's not there because someone's moved it. Someone has damaged it and it hasn't been replaced, or someone hasn't known that there's a care plan available. So again, the care plan can be created, but if it's never seen, it's useless. So there's efforts being made, but quite frankly, they're not good enough. Because again, you've written this document, but if you've not presented it in such a way to make sure that the clinicians who need to read it actually read it, it's useless. Back to the clinicians then. What's going on in the mindset of the clinician? Some of it I can understand as a doctor myself, and some of it I've had to learn as a patient and by doing research here. And it really boils down to the thinking that's done. There's subconscious knowledge that we have, and then there's conscious actual thoughts that we have to process information. The subconscious ones, it's all pretty much rooted in institutionalized discrimination, which means that there is a thought process and way of working that people in an institution, in a hospital, the healthcare industry in general, there's a way of working and thinking that everyone just tends to subscribe to. It doesn't mean that they deliberately want to discriminate against people. They're not deliberately racist or sexist. It's just that if their teacher was taught by their teacher that black patients tend to have a bit more tolerance for pain, that, women might be a bit more hysterical when they go to hospital, that drunks may not really have injured their head that much, that, children might be lying, where there is this belief that keeps them being passed down from one generation to the other, it just becomes the mindset that everybody has. They don't realize that the belief that they have is based on a lie, or at least based on an exaggeration. The next problem is the conscious part, where there's arrogance and ignorance, which is a very dangerous combination when it also coexists with fear. So you've got a clinician who has regularly throughout their lifetime, not just at medical school, maybe even before, been told, you're very intelligent, you're very capable, you always do such great work. So there's an assumption that when they see this sickle cell patient that they've never treated before, that they'll be able to do a great job. But they don't really know what they're doing because they did learn some stuff at medical school, but they haven't got the experience of dealing with the patient. So there's arrogance and ignorance. But there's a fear of being seen as a doctor who can't do a good job. Who wants to go to a doctor that doesn't know the disease that they're treating? Who wants to go to a doctor who doesn't trust their ability in treating the patient? So there's a fear that a lot of clinicians can have, and I've definitely experienced it, that you don't want to be seen as someone who can't get the job done. So you lie, so you avoid, and you only focus on what you know and what you're good at, which then leads to patients getting a small dose of morphine because the clinician is not used to giving a high dose, unless there's a clear indication, as far as they're concerned, to do so. They don't fully trust the patient because it's like, well, maybe you're lying because I've been told that patients like you lie. So there's a thinking that happens that's dangerous. Like thinking in healthcare, you'd be surprised how dangerous that is, paradoxically. Because generally speaking, as clinicians, we are taught to investigate and look for patterns. Because when you found a particular set of signs and symptoms, signs being what we see as clinicians of disease, and symptoms being what the patient reports of their disease, we look for that combination of signs and symptoms and say, that's a heart attack, that's a stroke, that's pneumonia, that's a sickle pain crisis. And then when you've got a diagnosis, it always links back to a treatment, or at least saying this is terminal, there's some, support treatment that we can offer. But a diagnosis always links to treatment. And so a lot of medicine is pattern recognition, not a lot of thinking. The thinking is, have I got enough evidence to accept this diagnosis? That's what normally the thinking is. But the next level of thinking that happens that's destructive is, does this patient deserve my time? Does this patient really deserve treatment? Is this patient actually going to get better if I help them or not? And that sort of thinking becomes very, very dangerous because a lot of people are not worthy of making those decisions and don't have the information to make the best decision to answer those questions.
And I feel like, there's a lot of debate between citizens, patients. I mean, I'm talking almost nonstop about it with my friends, which are parents getting older. And we see this arrogance, ignorance, and we see also that the system is not well built. So the physicians are struggling in the system as well. They are like overwhelmed by it.
Yes.
So when thinking about your research, and what I loved you said, it's not just, pointing out the problems, but looking into the solutions. And you can explicate on it as much as you want and go into different fields. But I'm especially interested if you ever had a chance and how it went to present the research to the physician.
Yeah, that's a good question. So what's interesting is that even amongst there being a lot of clinicians that are very arrogant and ignorant and unwilling to change, there's still a desire to do what's best for patients if the evidence backs it up. Because at the end of the day, clinicians are still scientists, really. So we provide evidence most of the time, the vast majority of the time, the evidence will then guide them towards a new way of working, because that is the basic concept in modern medicine, is to deliver evidence-based care. There must be evidence that backs up what we're actually doing to treat a disease, how we're diagnosing it and how we're then treating it. So I think it's also then presenting the information similar to in other industries and other scenarios in a way that doesn't make the clinician feel bad for doing something wrong, because that's an easy way to lose people and alienate people, and you're not winning hearts. So you're trying to blame them, even though they are to blame. But if this is how they've been taught and they're in an environment where this is the mindset, it's not one person to blame, it's a system to blame, actually. You should already feel motivated to be presented in a way that it's like, we as an industry can be doing better. This is what we see doesn't work, and this is what we see is a way of making things better. And this is the actual steps that you can take to make things better. So again, it's not just presenting the problem, it's highlighting, well, what's the solution and why you should trust the solution. And generally speaking, which is different to other aspects of stakeholder management, there is an aspect of, well, what's in it for me as a clinician? But what's in it for me as a clinician is my patient healthier after my intervention? That's what they care about most. And so if you're presenting your findings that's going to help them do their job better, clinicians tend to be very receptive to these findings, even if it shows that they've been doing a terrible job beforehand.
Okay, so there is this kind of self-reflection if brought up nicely, I would summarize, which is a human trait. Like doctors are also humans.
Correct.
Yeah. Is there maybe something that you would like to especially point out from the research that you did on this topic and we didn't yet mention?
Yes, I think a way of summarizing what I've said, but also being really clear on what this means from a practical perspective when you're working in digital health. You should design with discrimination in mind. Like, I can stop a clinician being racist, sexist, ageist, homophobic. I can't stop people having feelings, but I can influence their behavior based on the technology that I create and put out into the world, and the services that I design and put out into the world. It can influence their behavior. Can't guarantee it, but if you recognize that people are gonna have belief systems that can be destructive, it allows you to then have a new design constraint. You shouldn't see it as it's impossible now to make things better. As much as I know that the world is not perfect, it doesn't mean I don't strive for perfection. Shoot for the stars. You hopefully land on the moon, And what that means in a practical perspective, designing with discrimination in mind, you have to do some sort of meaningful behavior change work. You need to map out the processes we're already familiar with. You do some research, do some sort of journey mapping, and you maybe do a task analysis, some way of identifying opportunities to bring change, but being clear on where are the problem states, what are the root causes, where the steps in this task flow, which can lead to discrimination, and seeing, well, what tweak could bypass the discrimination. So even a racist doctor still has to treat patients and get them better, because if they're seen to do harm, they'll be fired, or worse, they'll be prosecuted. And one of the things that clinicians are very good at, they'll follow guidelines. If they're told to do your job, you have to follow these guidelines, they'll do it. There'll be exceptions, just like laws of the land. Some people will still ignore laws. That's why we have criminals, right? It's no in healthcare. But generally speaking, if it's like, this is our policy, this is our guidance, this is how we do things in this hospital, otherwise you don't have a job, people follow that. So that's what you need to try and do, is see how your digital health product or service already fits in with existing policies, or how you can change the policy. Changing policies and ways of working can be very, very difficult. You normally need the C-suite to get involved to some extent. Otherwise, it's seeing, well, how does this fit in with the general way of doing things at a high level? And that should normally lead to a change that can be easily adopted. And there's the other, common aspects of what we do. Your stakeholder engagement needs to be early. Your research needs to be throughout the process, regularly getting opportunities to get feedback and then bring changes. And it needs to be launch evaluations and continuous improvement going on. So there has to be regular engagement with the end user, and you have to have champions. You have to have key performance metrics so you can measure that success to see if there is improvement or not, and again make a change. But definitely understanding how what you're doing can still be successful despite there being people who might have less than positive intentions and ways of working.
Gyles, thank you. This is what I told you in my last recording, so I thank you for making it such a great one.
And thank you for having me. It's always a pleasure speaking with you and being part of this podcast.
Thank you for listening to UXR Geeks. If you enjoyed this episode, please follow our podcast and share it with your friends and colleagues. Your support is really what keeps us going. If you have any tips on fantastic speakers from across the globe, feedback, or any question really, we'd love to hear from you too. Reach out to geekspodcast@uxtweet.com. Special thanks go to my colleagues, to our podcast producer, Yekaterina Novikova, our social media specialist, Daria Krasovskaya, and our audio specialist, Melissa Danishura. And to all of you, thank you for tuning in.